So let's start this test and discussion session. This is the first MCQ. So the first part is about cell, suborganal and tests. Which of the following pathways only takes place in a cell cytoplasm? So what did you give as the right answer here? Is it glycolysis, beta oxidation, citric acid cycle, or urea cycle? Your answer should be glycolysis, right? Glycolysis happens in cells cytoplasm. Okay. Yes. So we know beta oxidation happens in mitochondria. Citric acid cycle happens in mitochondria. Urea cycle happens both in mitochondria as well as in cytoplasm. Okay, so using this MCQ, we are going to learn entirely about the various pathways happening in various suborganels. Okay, so that you get an overview of the entire biochemistry just by listening to this MCQ discussion. Okay, so let's start with glycolysis. Glycolysis happens where? It happens in cytoplasm. And for you to understand why glycolysis happens in cytoplasm, you need to know what is glycolysis. Right? It is there in the name. Glycolysis is glycolysis. So it's a process by which we split a 6-carbon compound called as glucose to form 2 products. And the 2 products that you get differ depending upon whether the process occurs aerobically or anaerobically. Okay, so let me tell you this. As we discuss all these MCQs, please repeat it along with me. Please memorize every fact that I'm telling you so that at the end of the session, you have a clear idea of the entire biochemistry. Okay, so the final product that you get from glycolysis depends upon whether the process occurs aerobically or anaerobically. When the process occurs aerobically, products formed are 2 molecules of pyruvate and 7 molecules of ATP. Whereas when the same process happens anaerobically, products formed are 2 molecules of lactate and 2 molecules of ATP. So can you all repeat this? What are the products of aerobic glycolysis? It is 2 pyruvate and 7 ATPs. Products of anaerobic glycolysis will be 2 lactate and 2 ATPs. So from now on, if somebody asks you what is the significance of glycolysis, your answer should be, this is the only pathway that can generate ATP even in the absence of oxygen. Do you understand this? There are so many pathways in your body that can give you ATP, but the only pathway that can give you ATP even in the absence of oxygen is glycolysis. Any pathway which is dependent on oxygen should happen in mitochondria. Whereas any pathway which is not dependent on oxygen can happen in cytoplasm. That is why glycolysis happens in cytoplasm. Are you clear about this? So where does glycolysis happen? It happens in cytoplasm. Now, what is PDH complex? Let me straight away give you all answers. I'm not going to expect you to start thinking and giving out answers. So I'm going to give you all answers straight away. What is PDH complex? PDH complex is a link between glycolysis and citric acid cycle. Do you understand this? PDH complex is a link between glycolysis and citric acid cycle. Just now I told you in glycolysis, you start from 1 molecule of glucose and you split this 1 molecule of glucose into 2 molecules of pyruvate. What should be the fate of these 2 molecules of pyruvate? Any fuel that enters into your body should ultimately get into citric acid cycle, because only then it can be released as carbon dioxide, which can be exhaled out. So what should be the fate of pyruvate? Pyruvate should also enter into citric acid cycle, for which pyruvate should become acetyl-CoA. So tell me which enzyme converts pyruvate into acetyl-CoA. That is done by pyruvate dehydrogenase complex. So don't get confused here. Pyruvate dehydrogenase complex converts pyruvate into acetyl-CoA. We all know that citric acid cycle, very good Som Subradas. So we all know that citric acid cycle happens in mitochondria. And where is PDH complex also present? That is also present in mitochondria. So do you understand the compartmentalization? Glycolysis happens where everybody? Glycolysis happens in cytoplasm. Pyruvate is formed in cytoplasm. Then pyruvate enters into mitochondria, wherein pyruvate dehydrogenase complex converts pyruvate into acetyl-CoA. Within mitochondria, then these acetyl-CoA molecules enter into citric acid cycle and they come out as carbon dioxide, which you can exhale out. Got it? So tell me again, where is glycolysis happening, all of you? Can you please keep the chat box active? Let's have this as an interactive session, everybody. Glycolysis happens in cytoplasm. PDH complex is present in mitochondria. Citric acid cycle happens in mitochondria. Okay. Now about glycogen metabolism. By glycogen metabolism, we mean both glycogen synthesis and glycogenolysis. Right? Glycogen metabolism includes both glycogen synthesis and glycogenolysis. Both these pathways happen in cytoplasm. Okay. Now about gluconeogenesis. First, you should know what is gluconeogenesis. Gluconeogenesis is a reversal of glycolysis. Do you understand this? Gluconeogenesis is a reversal of glycolysis. So tell me, what is glycolysis? In glycolysis, you start from one molecule of glucose. You split this one molecule of glucose into two molecules of pyruvate. So tell me, what is gluconeogenesis? You start from two molecules of pyruvate. You end up in one molecule of glucose. So what do you think will be the first step of gluconeogenesis? The first step of gluconeogenesis is catalyzed by pyruvate carboxylase. Okay, this pyruvate carboxylase converts pyruvate into oxaloacetate. Like PDH complex. Tell me, all of you, where is PDH complex present? I told you it is present in mitochondria. Similarly, pyruvate carboxylase is also present in mitochondria. So within mitochondria, pyruvate carboxylase converts pyruvate into oxaloacetate. Very good, Sudeepal. So within mitochondria, pyruvate carboxylase converts pyruvate into oxaloacetate, and then oxaloacetate enters into cytoplasm. In cytoplasm, it goes through reversal of glycolysis until you get glucose 6-phosphate. Okay. After you get glucose 6-phosphate, if I ask you to give a logical name to the enzyme which converts glucose 6-phosphate to glucose, you will call it as glucose 6-phosphatase. Are you clear? So tell me, what is the last enzyme of gluconeogenesis? Glucose 6-phosphatase, which converts glucose 6-phosphate into glucose. This glucose 6-phosphatase is present in endoplasmic reticulum. Do you all understand this? This glucose 6-phosphatase is present in endoplasmic reticulum. So, do you understand that gluconeogenesis involves three suborganelles? The first step alone happens in mitochondria. That step is catalyzed by pyruvate carboxylase. Very good, Meghal Shabriya. Yes. So, the first enzyme, pyruvate carboxylase, is present in mitochondria. The remaining steps happen in cytoplasm. The last enzyme, glucose 6-phosphatase, is present in endoplasmic reticulum. And as Meghal Shabriya has mentioned, endoplasmic reticulum is otherwise called as microsomes. Are you all clear about this? Endoplasmic reticulum is otherwise called as microsome. So if you ask which is the microsomal enzyme marker, right? That was the next question if I'm right. So which is the microsomal enzyme marker? It is glucose 6-phosphatase. Okay, so that's about gluconeogenesis happening in mitochondria, cytoplasm, and endoplasmic reticulum. Okay, now about HMP shunt. HMP shunt also happens in cytoplasm. Fatty acid synthesis again happens in cytoplasm. How about fatty acid oxidation? I just now told you oxidation pathways happen in mitochondria. So fatty acid oxidation happens in mitochondria. Very long chain fatty acids get oxidized in peroxisomes. Okay, very long chain fatty acids get oxidized in peroxisomes. So whenever you're asked about fatty acid oxidation, please remember it happens in mitochondria, but very long chain fatty acids get oxidized in peroxisomes. Now, cholesterol synthesis. Just remember that cholesterol is a steroid. Okay, cholesterol is a steroid. Steroids get synthesized in smooth endoplasmic reticulum. Okay, so you have rough endoplasmic reticulum and smooth endoplasmic reticulum. Rough endoplasmic reticulum is related to protein synthesis. Smooth endoplasmic reticulum is related to steroid synthesis. So cholesterol synthesis happens partly in cytoplasm and partly in smooth endoplasmic reticulum. Okay. Now about ketone body synthesis. Just remember, ketone bodies are products of incomplete oxidation of fatty acids. Do you all understand this? Ketone bodies are products of incomplete oxidation of fatty acids. Fatty acids get oxidized in mitochondria. So ketone bodies get synthesized in mitochondria. Do you all understand this? Ketone bodies get synthesized in mitochondria. For you to understand about fatty acid oxidation and ketone bodies, what is fatty acid oxidation? Okay. Suppose I give you palmitic acid. Palmitic acid has 16 carbon atoms. Stearic acid has got 18 carbon atoms. All of you please memorize it. Palmitic acid has 16 carbon atoms. Stearic acid has 18 carbon atoms. Let's just call all these as N carbon atom containing fatty acids. Okay, generalized. You're going to generalize all fatty acids as N carbon atom containing fatty acids. When they all undergo beta oxidation, products are always acetyl-CoA molecules. Okay, products are always acetyl-CoA molecules. What is acetic acid? Acetyl-CoA is nothing but acetic acid. Acetic acid has 2 carbon atoms. So from N carbon atom containing fatty acid, we always get N by 2 acetyl-CoA molecules. Okay, now what is the next step? In the next step, each and every one of these acetyl-CoA molecules, as I told you, should enter into citric acid cycle. Did I tell you every fuel should ultimately get into citric acid cycle and they should all come out as carbon dioxide? So acetyl-CoA should enter into citric acid cycle, then it comes out as carbon dioxide, which you can exhale out. In that case, you will call it as complete oxidation of fatty acids. Okay, but in some clinical conditions, acetyl-CoA will not be able to get into citric acid cycle. That is when acetyl-CoA accumulates and it condenses to form ketone bodies. So tell me, what are ketone bodies, everybody? Ketone bodies are products of incomplete oxidation of fatty acids. Do you all understand this? Ketone bodies are products of incomplete oxidation of fatty acids. Okay. And we know fatty acids get oxidized in mitochondria. So ketone bodies get synthesized in mitochondria. Okay. So that's about ketone body synthesis. Now, bile acid synthesis. Just remember, bile acids are derivatives of cholesterol. And bile acid is a steroid. And all steroids get synthesized in smooth endoplasmic reticulum, right? All steroids get synthesized in smooth endoplasmic reticulum. Now about urea cycle and heme synthesis. Both urea cycle and heme synthesis happen partly in mitochondria and partly in cytoplasm. Okay, both urea cycle and heme synthesis happen partly in mitochondria and partly in cytoplasm. So this is about pathways happening in various suborganelles. Are you clear? I hope it is clear to everybody. So a quick recall on whatever we have discussed so far. Glycolysis happens where? Can you all please start answering? Glycolysis happens in cytoplasm. PDH complex is present in mitochondria. Citric acid cycle happens in mitochondria. Glycogen metabolism, both synthesis and glycogenolysis happen in cytoplasm. Gluconeogenesis is a reversal of glycolysis. So, gluconeogenesis involves multiple suborganelles. The first step happens in mitochondria. The next few steps happen in cytoplasm, and then glucose 6-phosphatase happens in endoplasmic reticulum. Okay, HMP shunt happens in cytoplasm. Fatty acids get synthesized in cytoplasm. Fatty acids get oxidized in mitochondria or in peroxisomes. Okay. When do they get oxidized in peroxisomes? When it is a very long chain fatty acid oxidation. Cholesterol synthesis happens in smooth endoplasmic reticulum. So initial few steps happen in cytoplasm and then it happens in smooth endoplasmic reticulum. Ketone bodies get synthesized in mitochondria. Bile acids get synthesized in smooth endoplasmic reticulum, right? Because bile acids are also steroids. Bile acids get synthesized in smooth endoplasmic reticulum. Urea cycle happens partly in mitochondria and partly in cytoplasm. Heme synthesis also happens partly in mitochondria and partly in cytoplasm. Okay, so that's all about pathways and suborganelles. We know the answer, it is glycolysis. The marker enzyme for microsomes. Didn't we learn about this just now? For microsome is nothing but endoplasmic reticulum, and the marker enzyme for microsome is glucose-6-phosphatase. So quick recap about other choices. Galactosyl transferase is the marker enzyme for G. It is Golgi complex. Very good, everybody. Galactosyl transferase is the marker enzyme for Golgi complex. Cathepsins are the marker enzymes for lysosomes. I hope you all know lysosomes are loaded with proteases, which are cathepsins. Now, what is lactate dehydrogenase? It is related to glycolysis. Did I tell you in glycolysis, 1 glucose becomes 2 pyruvate? Then these 2 pyruvate become 2 lactate in the absence of oxygen. The enzyme which converts 2 pyruvate to 2 lactate is lactate dehydrogenase. So are you clear? Pyruvate is converted to acetyl-CoA by which enzyme? Pyruvate dehydrogenase complex that is present in mitochondria. Pyruvate is converted to lactate by lactate dehydrogenase that is present in cytoplasm. So lactate dehydrogenase is the marker enzyme for cytoplasm. Are you clear? So the answer for this MCQ is glucose-6-phosphatase. Okay. On prolonged starvation, which of the following tests will be positive? Right? So we know for on prolonged starvation, the person presents with ketosis. And ketosis or ketone bodies can be detected using Rothera's test. And I told you in Rothera's test, you see a purple colored ring. Very good. Excellent. So what is the answer? The answer is choice C. So this is a famous MCQ and this is an INI-CET MCQ. So on prolonged starvation, ketosis, and for ketone bodies, it is Rothera's test, which gives you a purple colored ring. So the answer is choice C. Okay, so let's discuss about other choices as well, right? That is how a test and discussion has to happen. So if you look at choice A, that is xanthoprotic acid test, right? What is it? It is xanthoprotic acid test that is answered by all aromatic amino acids. So if you're asking me what are aromatic amino acids, that would include phenylalanine, tyrosine, and tryptophan. Okay, so if you see an yellow color solution, please remember it is xantho. Xantho means yellow, right? So it is xanthoprotic acid test that is answered by all aromatic amino acids, including phenylalanine, tyrosine, and tryptophan. Okay, now what is this blue color becoming red? And that is Benedict's test. Right, blue color becoming red is Benedict's test, and that is for detecting the presence of reducing substances in urine. Right, that is for detecting the presence of reducing substances in urine. Now, what is this test? Urine turning dark on standing. Right, urine turning dark on standing is alkaptonuria. Right, so there are two possibilities for this. It is either alkaptonuria, in which case you don't have to add anything. The urine automatically turns black on exposure to air. Otherwise, it can also be a benzidine test. Right, it can also be a benzidine test, which is a test done to detect the presence of blood in urine. B for B. It is done for detecting the presence of blood in urine. Okay. So look at this. All of you please repeat this. This yellow color tube is xanthoprotic acid test. That is answered by all three aromatic amino acids, phenylalanine, tyrosine, and tryptophan. Blue color becoming red is Benedict's test. That is a test done to detect the presence of reducing substances in urine. This is Rothera's test done to detect the presence of ketone bodies. This can be alkaptonuria or it can be a benzidine test. Okay. Benzidine test is done to detect the presence of blood. Okay. There are so many questions that are asked about blood collection tubes these days. So let's learn all about blood collection tubes using this MCQ. Okay. So what color cap do you see here? Red color cap. Red color cap has which additive? Very good, Sudeep. Very good, Harshvardhan. Yes, it is silica. Right? Silica is a clot activator. Please remember, silica is a clot activator. For a red top tube, I have a mnemonic which is RSS. So what does RSS stand for? The first R stands for red. The next S stands for serum. So whenever you want a serum, you should stimulate clotting. And to stimulate clotting, the next S stands for silica. Do you understand this? So red, serum, silica. What will you use a red top tube for? This red top tube is used for any analysis that is done in biochemistry. Right? When I say it is done in biochemistry, that would include renal function test, liver function test, electrolytes, cardiac function test, right? Pancreatic function test, all hormone assays, right? So any test that is done in the biochemistry lab, done in a biochemistry lab, you will have to collect blood sample in a red top tube. You should allow the serum to get separated. In that serum, we are going to estimate urea, creatinine, electrolytes, bilirubin, AST, ALT. Got it? So that is about the red top tube. Apart from this, what are the other tubes that you should remember? So tell me about this tube. Gray top tube. G for G. Gray top tube is for glucose estimation. Okay. And why is it used for glucose estimation? Because a gray top tube has sodium fluoride and potassium oxalate, or sodium fluoride and sodium EDTA. There are two types. One has sodium fluoride and potassium oxalate. The other one has got sodium fluoride and sodium EDTA. In either case, fluoride inhibits enolase of RBCs. So all of you tell me, why is fluoride used here? Because fluoride inhibits enolase of RBCs. It does not allow RBCs to use glucose after sample collection. If you don't inhibit glycolysis in RBCs after sample collection, RBCs will continue to use glucose. So when you estimate glucose, that is going to give you a false low value. To avoid getting a false low value, collect a blood sample in a tube with fluoride, and that is a gray top tube. G for G, it is used for glucose estimation. Very good. And then have you all seen a lavender top tube? You must have all collected blood sample in a lavender top tube. So lavender top tube has got K2 EDTA or K3 EDTA. Yeah, lavender top tube has K2 EDTA or K3 EDTA. EDTA chelates calcium. Okay. After calcium is chelated, there is no clotting process. When there is no clotting process, what separates above is called as plasma. Do you understand this? When there is no clotting that is happening, what separates above is called as plasma. So when am I going to inhibit clotting? In few scenarios, I will want to inhibit clotting whenever I need a whole blood sample. When do I need a whole blood sample? For complete blood count. In complete blood count, I want to estimate RBCs. I want to estimate the count of WBCs. I want to estimate the count of platelets. In that case, if I allow clotting to happen after sample collection, in the clot, all cells get entangled. So I will not be able to count the number of cells in the sample. So I don't want clotting to happen. What I do, I collect a blood sample in a tube with EDTA. EDTA chelates calcium, and what separates above is plasma. Just before analysis, I mix the sample. I then introduce it to an analyzer. I count the number of cells and I give the report. Okay, so complete blood count. Or whenever HbA1c has to be estimated. So what is HbA1c? It is glycated hemoglobin. So for me to estimate glycated hemoglobin, I want RBCs to be intact, right? If I allow clotting to happen, all RBCs will be trapped within the clot. I cannot lyse that RBC. I cannot allow the hemoglobin to be released. So whenever I have to estimate HbA1c, I want the cell to be intact. So I collect that sample with EDTA and then I lyse RBCs. Hemoglobin comes out, I measure it and then I give the report. So for HbA1c also, you need to collect that sample in a lavender top tube. And whenever there is a labile parameter like parathormone or ACTH or ammonia that need to be estimated. Okay, parathormone, ACTH or ammonia need to be estimated. So why am I calling these as labile parameters? Because they are susceptible to inhibition by proteases. When there is a protease in the medium, it degrades all small peptides. So parathormone level will be falsely low. ACTH level will be falsely low. But I want to protect these parameters until I estimate. I don't want these proteases to be active in that case. So I collect blood sample in a tube which has got EDTA. EDTA chelates calcium, does not allow proteases to be active so that these labile parameters are preserved. Okay, so when will you collect a blood sample in a lavender top tube with EDTA? Whenever I want a whole blood sample like complete blood count, or whenever HbA1c has to be estimated, or whenever labile parameters like parathormone, ACTH or ammonia need to be estimated. Are you clear, everybody? Good. Now, this one, blue top tube, right? Blue top tube is a citrated tube. When I say citrated tube, it has 3.2% sodium citrate. And C for C, that is used for coagulation assays. Okay, C for C, it is used for coagulation assays. Whenever prothrombin time, activated partial thromboplastin time, fibrinogen assays have to be performed. Whenever factor assays have to be performed. Right, in all these cases, it has to be collected in a citrated tube which has 3.2% sodium citrate. Okay. Now, what is 3.8% sodium citrate? If it is 3.8% sodium citrate, then it is a black topped tube. And a black top tube is used for ESR, erythrocyte sedimentation rate, can be estimated by collecting blood sample in a black top tube which has 3.8% sodium citrate. Good. Now tell me about this green topped tube. Green top tube is a heparinized tube, right? It can have either sodium heparin or it can have lithium heparin. We have both the types of blood collection tubes. For both, it is a green top tube. So when will you use a heparinized tube? Please don't say it is ABG. For ABG, you should not collect it in a tube. You should collect the sample in a syringe. Okay, so heparinized tube is used whenever you have to estimate or whenever molecular diagnostics have to be done or whenever cytogenetic assays have to be performed. Or in other words, whenever DNA or RNA needs to be extracted. Do you understand this? Whenever DNA or RNA needs to be extracted, it has to be collected in a green top tube which has got sodium or lithium heparin. That is one application of a heparinized tube. Another application of a heparinized tube is whenever stat analysis needs to be done. What do I mean by stat or quicker analysis? Can anybody tell me? Stat or quicker analysis is essential for estimating TROP-T values, wherein the window period is too narrow. Right? In that case, I should not be collecting blood sample in a red top tube just because I said for all biochemistry, the sample has to be collected in a red top tube. Because if you collect in a red top tube, then it takes its own sweet time to clot, sweet time for the serum to get separated, right? So the window period will be lost. In that case, collect blood sample in a green top tube which has heparin. You can immediately centrifuge. In the plasma, you can estimate trop T, or you can estimate parathormone, intraoperative parathormone. Okay, so when we'll use a heparinized tube, everybody? ABG cannot be done in this tube because Biswas, for ABG, it has to be an anaerobic sample collection. What do I mean by anaerobic sample collection? The blood sample that you collect for arterial blood gas analysis should not be exposed to the atmospheric air. If you expose it to atmospheric air, the partial pressure of oxygen in the sample will get equilibrated with the atmospheric air, causing false PO2 and false PCO2 values. Do you understand this? If you are collecting blood sample in a tube, this tube has got a column of air. So PO2, PCO2, all these will get altered. That is why what are you supposed to do? Collect it in a syringe. And even in a syringe, you're not supposed to pull the plunger. What should you do? Just insert the syringe into the artery. The arterial pressure just rises the plunger. Okay, because even if you pull it, one bubble of air that gets inserted into the sample will affect PO2 and PCO2. And after sample collection, I'm sure you would have been trained to bend the needle. If you don't bend the needle, the bore of the needle is in touch with the atmospheric air. That will also affect PO2 and PCO2. Not because the machine is not compatible. Please understand. Yeah, please understand. It is not because the machine is not compatible for a tube. You make a machine based on what you have designed previously, right? So we know we cannot collect it in a tube. That is why the machine has got a small probe into which only syringe can be inserted. It is primarily because you don't want it to be exposed to atmospheric air. Definitely no, ABG is not done in a green tube. I'm 100% sure. Okay, so that's about a green top tube. No one taught this during your internship. That is why you're learning everything now, right? Because when you become a resident, you're not going to commit such mistakes. It's never too late. Government setup, we have heparinized. We have to collect it in a heparinized syringe. Not only in government setup, even in a private lab or private place, it is only a heparinized syringe, right? So the syringe has to be coated with the heparin, and then you flush it and then you collect. Red top tube you cannot use for ESR, please. Red top tube should not be used for ESR. For ESR, if it is Wintrobe's method, the only tube that is allowed is black topped tube. Okay. For automated ESR analysis, you can use a lavender top tube. Are you clear? For ESR, Wintrobe's method, you'll have to use only a black top tube. If it is an automated ESR analyzers that are available these days, they are compatible with both black top tube, black top tube as well as with the EDTA tubes. So the last color is this. Have you all seen this? Yeah, have you all seen this? Yellow top tube. So yellow top tube has a gel at the bottom, right? So what is this? This is called as a gel and a clot activated tube. Meaning this tube has got a gel at the bottom and it is sprayed with the same silica which I showed on the red top tube. So what is the difference between a red top tube and a yellow top tube? Both have the same clot activator spray. So both allow serum to get separated. But the difference is red top tube does not have a gel. Yellow top tube has a gel. Okay. So what do we do here? In a gel and a clot activator tube, you collect a blood sample. When you collect blood sample, first the blood sample will be on top of the gel. After collecting, you centrifuge the sample, right? When you centrifuge the sample, because of differences in sedimentation coefficient, the gel will rise up and it will stand like a mechanical barrier. Where is the gel now? It has rised up and it is standing like a mechanical barrier between cells at the bottom and serum on top. Do you understand this? Between cells at the bottom and serum on top. So that anything which happens in the cell layer does not affect the serum. Do you get it? Because after sample collection, slowly any cell will undergo lysis. Because after sample collection, the metabolism of cell is affected. In due course, a cell will undergo lysis. Whenever cell undergoes lysis, intracellular fluid of RBCs, intracellular fluid of platelets will contaminate the serum. And that will cause false low and false high values. We don't want that to happen. So I'm going to place a mechanical barrier that is done by a gel. So when will you use a gel and a clot activated tube? Whenever the sample has to be transported for a prolonged period of time, or whenever the sample has to be stored for a prolonged period of time, then you will have to use a gel and a clot activated tube. For example, all private laboratories which have satellite collection centers, or private laboratories wherein they go for home collection. Right. So what they do, if it's a satellite center, they collect that sample in a gel and a clot activated tube. In the satellite center, they centrifuge it. The gel will act like a mechanical barrier so that during transportation or during storage, even if the cell undergoes lysis, you don't get false high or false low values. So when we'll use a gel and a clot activated tube? Gel and a clot activated tube is used for the same purpose of red top tube. Right? When I say red top tube, this is also used for biochemistry. This is also used for renal function test, liver function test, thyroid function test, pancreatic function test, cardiac function test, hormone assays. For all these, you'll have to use yellow top tube if the sample has to be transported or if the sample has to be stored. Are you all clear about this? Yeah, so that's about the various types of blood collection tubes. So tell me, what is the additive that is used in the given blood collection tube? What color cap is it? Red color cap for serum separation because it has got silica, which is a clot activator. Okay, so let's discuss few other MCQs apart from what you saw in the exam paper, right? So this is a recently asked MCQ, INI-CET November 2024. The tube used for serum electrolyte estimation. Happy that it's useful, Ramesh Kumar. The tube that is used for serum electrolyte estimation is, what did you all choose as the right answer for this MCQ? Not today. What will you choose it as an MCQ? What will you choose as an answer for serum electrolyte estimation? Yes, very good. The answer is yellow. Okay, so tell me, why not lavender? For electrolyte estimation, why not use lavender? I should not use lavender because lavender has got, what is the additive? K2-EDTA or K3-EDTA, right? In either case, potassium values will be falsely high. Calcium values will be falsely low. So don't use a sample that is collected in a lavender top tube for electrolyte estimation any day, right? What about a green top tube? You cannot use because green top tube has got sodium fluoride and potassium oxalate. Again, tell me, what happens to sodium? High. What happens to potassium? High. It has sodium, it has potassium. Sodium and potassium will be high. What happens to calcium? Oxalate chelates calcium ions. Calcium values will be low. So no green top tube, no gray top tube. No gray top tube can be used for sodium fluoride and potassium oxalate. It cannot be used for electrolyte estimation. How about a green top tube? What does a green top tube have? Green top tube has heparin. So can you use a sample that is collected in a heparinized tube for electrolyte estimation? You can, because heparin is not going to cause any defect if it's a lithium heparin, right? If it's a lithium heparin, it does not affect any electrolyte value. So if you collect that sample in lithium heparin tube, you can use it for electrolyte estimation. But in that case, you cannot call it as a serum electrolyte estimation, right? What should you call it as? You should call it as a plasma electrolyte estimation because there is an anticoagulant. Do you understand this? Because of the way question is asked, I am not going to choose green. I am going to choose yellow. Got it? That is why I always say you have to be very mindful about answering an MCQ, right? Your 100% focus should be on the question. Read the stem thoroughly and then exclude choices. Always try to find out why not this choice, right? Exclude it and then arrive at a right answer. Which anticoagulant is ideal for blood sample for HbA1c estimation? Please tell me the right answer for HbA1c estimation. What is to be used? I told you EDTA. Right. Good. The most widely used technique for HbA1c estimation is, right? This is also an INI-CET MCQ. For HbA1c estimation, it is ion exchange chromatography, because the question is the most widely used. Okay, but remember, for glycated hemoglobin estimation, we have ion exchange chromatography, we have affinity chromatography, we have electrophoresis, we have immunoassays. So we have techniques covering all these technologies for HbA1c estimation. But because the question is most widely used, your answer should be ion exchange chromatography. Because the first time when they came up with HbA1c as a parameter for assessing long-term glycemic control of an individual, right, they used only ion exchange chromatography. So all treatment goals that we have now, ADA treatment goals, those are based on the values which we got from ion exchange chromatography. That is why clinicians prefer to have a value from ion exchange chromatography. Do you understand this? So few facts about HbA1c estimation in terms of what are the limitations. You know the advantage. Fasting plasma glucose, postprandial plasma glucose is like a screenshot, right? It's like a screenshot of plasma glucose value at that time. It will not tell you what has happened in the last few weeks or last few days. Okay. So I want to assess long-term glycemic control of my patient, for which I'm going to estimate glycated hemoglobin. That is the advantage. Okay. Now, what are the limitations? The obvious limitation is glycated hemoglobin is based on the assumption that lifespan of RBC is 120 days. We just assume that the lifespan of everybody's RBC is 120 days. We just assume that an RBC has been alive in the circulation for 120 days, and then we estimate how much of this RBC has been glycated, and then we relate it to the last 6 to 8 weeks of plasma glucose. Okay. Now, what happens if a person has got iron deficiency anemia? Why HbA1c in lavender sky? I explained lavender has EDTA. EDTA chelates calcium, no clotting. So you have a whole blood sample. Only when it's a whole blood sample, cells can be lysed. Only then hemoglobin can come out. Do you understand this? What if you allow it to undergo clotting? If it undergoes clotting, all RBCs are trapped in the clot. Right. So even if you add a lysate agent, it is not going to cause lysis of RBCs. You will not get hemoglobin coming out. That is why it has to be done in a EDTA tube. Okay. So ion exchange chromatography, I can explain, but nobody is going to ask you about it. It is all based on the fact that your glycated hemoglobin is positively charged. Okay. So in ion exchange chromatography, the stationary phase is positively charged. In any chromatography, we have a stationary phase and a mobile phase. In ion exchange chromatography that is used for HbA1c estimation, the stationary phase is positively charged. Okay. So, I'm sorry, it holds on to cations, right? So it is going to hold on to cations, which means they are all negatively charged. So what happens when they are all negatively charged? When you pour the hemolysate, because HbA1c is positively charged, it comes and gets attached to the stationary phase. So HbA1c is now attached to the stationary phase. After you remove everything else, then you get back what you want during elution. So only HbA1c comes out at a later phase. You measure that hemoglobin and you give the value. If you know this, that is enough. We call it as cation exchange chromatography. Do you all understand this? We call it as cation exchange chromatography. Now coming back to what we were discussing, what happens in iron deficiency anemia? The body senses that there is iron deficiency. So the body does not allow cells to undergo lysis. They want to protect RBC so that the iron is conserved. Okay. So RBCs don't die after 120 days. Their lifespan is prolonged. If lifespan of RBC is prolonged, it means these RBCs are getting exposed to carbohydrates for a prolonged period of time. So more hemoglobin will be glycated, and that causes falsely elevated values. Do you understand this? In iron deficiency anemia, the cell turnover is reduced. RBC lifespan becomes higher than 120 days. So for a prolonged period of time, RBCs are exposed to carbohydrate residues. So it is falsely elevated. Okay. And do you think iron deficiency anemia is common or is it uncommon? Can you all tell me? Yes, and Fernandez, you'll have to wait, right? We have so many MCQs. We have MCQs on hyperlipidemia. I will be discussing about that. So my humble request to all of you who are watching this session is not to feel missing out on what is not being discussed now. Do you all understand that? Be mindful about what is getting discussed now because it is a high yield session. Every fact that I discuss has got significance. So please please put your mind into what I'm discussing, watch it, memorize it. Okay. So don't talk about what has been not discussed now. It will be discussed. Yes, it is quite common, right? Iron deficiency anemia is very common. And that is why falsely elevated HbA1c is a common condition. And what happens is, in this case, the diabetologist sees a person with a HbA1c value as high as 8. Okay, so the person starts increasing the dose of anti-diabetic drug, and that causes hypoglycemic episodes. So a lady who's presenting with repeated hypoglycemic episode, right? The reason could be because the person has got iron deficiency anemia and the report HbA1c report value is falsely elevated. So do not interpret HbA1c values not having a hemogram already done. Do you understand this? You should have a complete hemogram done and then you can interpret HbA1c values. Otherwise, that can be falsely elevated values in iron deficiency anemia. Similarly, in hemolytic anemia, what happens in hemolytic anemia? RBC lifespan is reduced. So for a shorter period of time, this hemoglobin has been exposed to carbohydrate residues. So that gives you false low values. Okay. So what are the limitations of glycated hemoglobin? That can be falsely elevated values in iron deficiency anemia, false low values in hemolytic anemia. That is why in these conditions, don't estimate HbA1c value. Instead, you can estimate fructosamine. So all of you tell me what is fructosamine? Fructosamine is glycated albumin. Do you understand this? Fructosamine is glycated albumin. So this is not affected by RBC's lifespan getting affected. Okay, so whenever you see a patient with an aberrant lifespan of RBCs, either because of iron deficiency anemia or because of hemolytic anemia, estimate fructosamine, which is glycated albumin. Okay, but albumin lifespan is not as long as 120 days. So when glycated hemoglobin reflects the last 6 to 8 weeks of glycemic control, fructosamine reflects only the last 3 to 4 weeks of glycemic control. So the disadvantages, last 3 to 4 weeks is what you can assess if it is fructosamine. The advantages, if lifespan of RBC is affected, you can estimate fructosamine. But listen to this, with all this continuous glucose monitoring devices that we have currently, I hope you all know, now not only diabetic individuals, even those who are health freaks, right? They want to assess their glucose level at any point in their life. So what do they have? They have this continuous glucose monitors. So with the advent of continuous glucose monitor, I feel or I predict that HbA1c will soon lose its importance. Okay. So that is about fructosamine. So tell me an answer for this. This is also an INI-CET MCQ. Long-term glycemic control in a person with hemolysis is assessed by estimating fructosamine. All of you tell me what is fructosamine. It is glycated albumin, which is a protein. Very good. This is another INI-CET November 2021 MCQ, right? Proteins can be precipitated by all excepts. Proteins can be precipitated by alkaloidal reagents like trichloroacetic acid, or they can be precipitated by organic solvents like acetone. Sulfosalicylic acid is also an alkaloidal reagent which can cause protein precipitation. Okay, and proteins can be precipitated by bringing the protein solution close to its isoelectric pH. Okay, close to isoelectric pH. So when you move it away from isoelectric pH, proteins will not get precipitated. They become more and more soluble. Right? So for you to understand what exactly am I telling you, because you cannot just memorize this, right? You cannot just memorize that alkaloidal reagent like sulfosalicylic acid, trichloroacetic acid can cause protein precipitation, acetone can cause protein precipitation, and I have to bring it to isoelectric pH. So why do you think bringing it to isoelectric pH will cause protein precipitation? It is because water solubility. A protein will be soluble in a polar solvent like water, right? Provided it has a charged shell. Do you understand this? Provided it has a charged shell, or provided, so any charge is okay. It can be positively charged or it can be negatively charged. Okay. So they have to interact with water. Only until they interact with water, they're going to be soluble in water. So one requirement for a protein to be soluble in water is it should be surrounded by a charged shell. Okay. Or there should be a hydration shell. This hydration shell also enables the protein to be soluble in a polar solvent like water. So what happens in the presence of an organic solvent like acetone? The organic solvent like acetone removes the hydration shell. So when without hydration shell, it cannot be soluble in water, it gets precipitated. Okay. Alkaloidal reagents like trichloroacetic acid and sulfosalicylic acid remove the charged shell, remove the hydration shell, allow the protein to get precipitated. Now, what is isoelectric pH? Isoelectric pH is the pH at which the net charge carried by the particle is zero. Are you clear? What is isoelectric pH? It's a pH at which net charge carried by the particle is zero. Once the charge becomes zero, no more interaction with water and it gets precipitated. Do you all understand this? So how can you precipitate proteins? You can precipitate proteins using organic solvents which can remove the hydration shell, or alkaloidal reagents like trichloroacetic acid and sulfosalicylic acid which can remove both hydration and charged shell. Isoelectric pH, the net charge is zero, no more interaction, it gets precipitated. So what is the right answer, everybody? The right answer is choice B. Got it? The group that is present in tryptophan. All of you tell me what is the right answer. The group that is present in tryptophan. The answer is choice C, indole group. Okay. So they keep asking you this. What is the group that is present in arginine? You should know it is guanidinium. What is the group that is present in histidine? You should know it is imidazole group. Okay. So now when I say, you can just memorize, okay, these are the groups, these are the amino acids. And then they ask you about color reactions. So let me give you 4 mnemonics for amino acids for you to remember the group that is present and for you to remember the color reaction that they answer. Okay. So what are the 4 mnemonics? Let's start with HIP. The first one is HIP. The second one is TIA. The third one is AGS. The last one is MPS. Do you know HIP? TIA is transient ischemic attack. Then you have AGS. MPS is mucopolysaccharide. Right? So what are we going to use this mnemonic for? All of you listen to this. Good, Sudeepal. What does HIP stand for? Histidine has imidazole group. Right? Histidine has imidazole group and it answers Pauli's test. Okay, histidine has imidazole group. It answers Pauli's test. TIA, tryptophan, has an indole ring and it answers aldehyde tests. Okay, tryptophan, indole ring, it answers aldehyde test. AGS, arginine, guanidinium group, and it answers Sakaguchi test. Okay, arginine, guanidinium group, it answers Sakaguchi test. MPS is the mnemonic to remember those color reactions which give you red color. So what are the red color reactions? M stands for Millen's test. P stands for Pauli's test. S stands for Sakaguchi test. Okay, Millen's test, Pauli's test, and Sakaguchi test give you red color reaction. Have you all understood this? So HIP stands for histidine with an imidazole group, answers Pauli's test. TIA, tryptophan, has an indole ring, answers aldehyde test. AGS, arginine, has guanidinium group, it answers Sakaguchi test. MPS give you red color reaction, Millen's, Pauli's, and Sakaguchi test. All these are red color reactions. Okay. So we know the answer, tryptophan has an indole group. Which molecular method is used to detect RNA? Okay. RNA can be detected using reverse transcriptase PCR. Right? RNA can be detected by reverse transcriptase PCR. So tell me, what is transcription, everybody? Can all of you tell me what is transcription? Transcription is DNA to RNA. So what is reverse transcription? RNA to DNA is reverse transcription. So to detect RNA, we need a reverse transcriptase PCR. Got it? Now, how am I going to exclude other choices? Western blot is for protein detection. Right? Western blot is for protein detection. Just remember, Southern blot is for DNA detection. You can remember it as South Indians like dosa. Right? South Indians like dosa. So Southern blot is for DNA identification. Northern blot is for RNA identification because North Indians like roti. Okay, so Northern blot is for RNA identification. Western blot is for protein identification. So to detect RNA, can I use Western blot? No, I cannot. Okay, what is Sanger's sequencing? Sanger's sequencing is for sequencing DNA, not for sequencing RNA. Okay, Sanger's sequencing is for sequencing DNA, not for sequencing RNA. G banding. G banding is nothing but the karyotyping image that you have seen in your textbook, right? For detection of Down syndrome, for detection of Turner syndrome. Have you seen a karyotyping image wherein all chromosomes are arranged? And then if there is trisomy, you see that chromosome 21 alone, there are 3 chromosomes, 3 copies. So that is obtained by Giemsa staining of the chromosome. That is called as G banding of chromosome. Chromosome is a DNA. So G banding or Giemsa staining can be used for DNA, not for RNA. So the first part is over. Let's proceed to part 2, which is about an introduction to metabolism. Okay, so I will be telling you an introduction to metabolism here, a comprehensive idea of which is necessary for you to answer MCQs on metabolism. Okay, so I will quickly go through this. Okay, it is not a long-term session for me to sit and analyze everything, but I'll help you to get an overview. Okay, so we all know metabolism has got 2 components, catabolism and anabolism. We know catabolism is breakdown, right? It is breakdown. When you break down complex biomolecules into simpler substances. Whenever you break down complex biomolecules into simpler substances, we know energy will be liberated. Whenever energy is liberated, that energy has to be trapped in the form of ATP. We know that, right? Energy has to be always trapped in the form of ATP because ATP is the energy currency. Now, depending upon how we trap the energy in the form of ATP, catabolism is of 2 types. One is substrate level phosphorylation. No, Northern blot was not an option. If Northern blot was an option, then yes, you can choose Northern blot as well. Because Northern blot is for RNA identification. Okay, so depending upon how you trap the energy in the form of ATP, catabolism is of 2 types. One is substrate level phosphorylation. The other one is oxidative phosphorylation. So what is substrate level phosphorylation? Here, at the substrate level itself, you trap the energy in the form of ATP. Do you understand this? Here at the substrate level itself, you trap the energy in the form of ATP. Let's keep it very simple. Okay. You're learning a pathway. It can be glycolysis. It can be citric acid cycle. You're learning some pathway. In that pathway, you see that in one step, directly ADP is becoming ATP. Right? You're learning a pathway. In that pathway, you see a step wherein ADP directly becomes ATP. That is called as substrate level phosphorylation, because phosphorylation is happening at the substrate level. Okay. That is why all substrate level phosphorylation enzyme names end with a kinase. Because only when it is a kinase, ADP can be converted to ATP. Whereas what is oxidative phosphorylation? In oxidative phosphorylation, which is a type of catabolism, energy is liberated. That energy is trapped as NADH or FADH2 first. Do you understand this? In this type of catabolism, energy is liberated. The energy is not directly trapped as ATP. The energy is trapped as NADH or FADH2. And then you push NADH or FADH2 through electron transport chain, which in a complex way helps you in phosphorylating ADP to form ATP. That is called as oxidative phosphorylation. Again, let's keep it simple. You are learning a pathway, right? In that pathway, you see that there is one step wherein NADH or FADH2 is formed. And then you're seeing that you're dependent on electron transport chain to translate this NADH or FADH2 as ATP. Then that is an example of oxidative phosphorylation. Got it? That is why oxidative phosphorylation enzyme names end with dehydrogenase. Are you clear? Substrate level phosphorylation enzyme names end with a kinase. Oxidative phosphorylation enzyme names end with a dehydrogenase. Okay. Here you need to know two more facts. Okay. The first fact is, do you see that it is never NADPH? I never said NADPH. I only said NADH or FADH2. Because NADPH cannot enter into electron transport chain. NADPH can never give rise to ATP. Okay, it has to be either NADH or FADH2. This is fact number 1. Fact number 2 is, because we are all aerobic organisms, most of our catabolic steps will belong to which type of phosphorylation? Oxidative phosphorylation type. There are only 4 examples of substrate level phosphorylation which you should memorize. Okay. So what are the 4 examples of substrate level phosphorylation? The first example is phosphoglycerate kinase. The second one is pyruvate kinase. Okay. Phosphoglycerate kinase and pyruvate kinase of glycolysis. The next one is succinyl thiokinase of citric acid cycle. The last one is creatine kinase of muscle. Okay. So have you all memorized it? I want everybody to answer this. What are the 4 examples of substrate level phosphorylation? Because remaining catabolic steps are all oxidative phosphorylation type. So what are the 4 examples? Phosphoglycerate kinase and pyruvate kinase of glycolysis, succinyl thiokinase of citric acid cycle, creatine kinase of muscle. Other than these 4 examples, we have only dehydrogenases which keep generating NADH or FADH2. Okay, so that is an introduction to metabolism. Now about integration of metabolism. In integration of metabolism, first I'm going to tell you about effects of hormones, and then we are going to discuss about what happens when there is low energy and what happens when there is high energy. Okay, so all of you start answering. When I say about effects of hormones, tell me what happens in the well-fed state. Suppose you are well-fed. What happens to your plasma glucose? Plasma glucose level is high. When the plasma glucose level is high, which hormone will be released into the circulation? High glucose, insulin will be released into the circulation. Okay, insulin level increases. When insulin level increases, you know insulin is an anabolic hormone. So insulin being an anabolic hormone, it stimulates all anabolic pathways and simultaneously it inhibits all catabolic pathways. So tell me, what are the anabolic pathways stimulated by insulin? Insulin stimulates glycolysis. It stimulates glycogen synthesis. Okay, glycolysis, glycogen synthesis. If you're asking me why should insulin stimulate glycolysis and glycogen synthesis, because the primary aim of insulin is to reduce the blood glucose level. To reduce the blood glucose level, it should stimulate the cell to use glucose. Do you understand this? It should stimulate the cell to use glucose. You know, a cell can use glucose either through glycolysis or through glycogen synthesis. So insulin stimulates glycolysis and glycogen synthesis. It stimulates fatty acid synthesis, cholesterol synthesis, triacylglycerol synthesis. It stimulates protein synthesis. Okay. Simultaneously, it inhibits all catabolic pathways. So what are the catabolic pathways inhibited by insulin? Insulin inhibits glycogenolysis. It inhibits gluconeogenesis. You should ask me why. It's because if there is glycogenolysis and gluconeogenesis, plasma glucose will increase. I don't want my plasma glucose to increase. So what does insulin do? Insulin inhibits glycogenolysis. It inhibits gluconeogenesis. It inhibits peripheral lipolysis. Right? It inhibits peripheral lipolysis. It inhibits fatty acid oxidation. It inhibits protein breakdown. It inhibits amino acid oxidation. So all catabolic pathways are inhibited by insulin. Do you all understand this? So what are the pathways inhibited by insulin? All catabolic pathways, which include glycogenolysis, gluconeogenesis, peripheral lipolysis, fatty acid oxidation, protein breakdown, and amino acid oxidation. Okay. Now what happens in starvation? Can you all start answering? What happens in starvation? In starvation, tell me what happens to blood glucose level? Decreases. When glucose level decreases, no insulin release. Instead, counter-regulatory hormones are released. Tell me, what are the counter-regulatory hormones? Glucagon, growth hormone, norepinephrine, cortisol. So can you all repeat this? What are the counter-regulatory hormones of insulin? Glucagon, growth hormone, norepinephrine, cortisol. All these counter-regulatory hormones of insulin are all catabolic, right? When they're all catabolic, what do? They do the exact opposite of insulin. So they stimulate all catabolic pathways and they inhibit all anabolic pathways. So tell me, what are the catabolic pathways stimulated by glucagon and other counter-regulatory hormones? Whatever I told you that, just reverse. Okay. So it stimulates glycogenolysis and gluconeogenesis so that plasma glucose is increased. It stimulates peripheral lipolysis. It stimulates fatty acid oxidation. It stimulates protein breakdown. It stimulates amino acid oxidation. Everything is broken down when you're starving. Okay. In contrast, it inhibits all anabolic pathways. So tell me, what are the anabolic pathways inhibited by these counter-regulatory hormones? It inhibits glycolysis. It inhibits glycogen synthesis. It inhibits fatty acid, cholesterol, triacylglycerol synthesis. It inhibits protein synthesis. Do you get it? So this is about effects of hormones, what happens in a well-fed state and what happens in starvation. Are you clear? So now let's learn about what happens in low energy and what happens in high energy to glucose. Okay, you know everything. You have to just summarize it. Okay, when there is low energy, what happens to glucose? All of you start answering. When there is low energy, glucose is split into what? 2 molecules of pyruvate. If glucose becomes 2 molecules of pyruvate, how many ATPs do we expect? we expect 7 ATPs. This is when there is oxygen. Okay. What if there is no oxygen? When there is no oxygen, these two pyruvate become lactate. If a cell decides to form lactate instead of pyruvate, you cannot expect 7 ATPs. Did I tell you if it becomes lactate, it is only 2 ATPs. Okay. So when there is no oxygen, glucose becomes 2 lactate and 2 ATPs. What if there is oxygen? If there is oxygen, the pyruvate that is formed should give you more energy by entering into citric acid cycle. How does pyruvate enter into citric acid cycle? After becoming acetyl-CoA. So can you all tell me which enzyme converts pyruvate into acetyl-CoA? Please answer. The enzyme which converts pyruvate into acetyl-CoA is pyruvate dehydrogenase complex. Do you see that it's a dehydrogenase? What does a dehydrogenase do? Removes hydrogen from pyruvate, gives that hydrogen to its coenzyme. And what is its coenzyme? Its coenzyme is NAD that gets converted to NADH. This NADH enters into electron transport chain, gives rise to how many ATPs? 2.5 ATPs. When 2 pyruvate become 2 acetyl-CoA, 2 NAD become 2 NADH, equivalent to how many ATPs everybody? 5 ATPs. Okay, so till now how many ATPs have you got? 7 through aerobic glycolysis, 5 because of PDH complex, because 2 pyruvate become 2 acetyl-CoA. Okay, and then every acetyl-CoA enters into citric acid cycle. Every citric acid cycle gives you 10 ATPs. So totally 20 ATPs. 20 plus 5 is 25. 25 plus 7 is 32 ATPs. So all of you, please don't forget this. When glucose undergoes complete oxidation, what do you mean by complete oxidation? Glucose becoming carbon dioxide. So when glucose undergoes complete oxidation, we get 32 ATPs. Do you all understand this? So please tell me what happens when there is low energy. Whenever there is low energy, your cell tries to extract energy from glucose, for which glucose enters into glycolysis. Glucose becomes 2 pyruvate. We get 7 ATPs. Further fate of pyruvate depends upon whether there is no oxygen or if there is oxygen. When there is no oxygen, no other go, pyruvate become lactate. If pyruvate becomes only lactate, you get only 2 ATPs. If there is oxygen, pyruvate should enter into citric acid cycle by becoming acetyl-CoA. The enzyme is pyruvate dehydrogenase complex that forms 2 NADH, equivalent to 5 ATPs. So 7 plus 5 is 12 ATP. Then every acetyl-CoA enters into citric acid cycle. Every cycle gives you 10 ATPs. So 20 plus 12 is 32 ATPs. When glucose undergoes complete oxidation, it is 32. This is when there is low energy. Now, what if there is high energy? Even when there is high energy, the basic skeleton remains the same. So tell me, what do I mean by basic skeleton? Even here, 1 glucose becomes 2 pyruvate. Even here, 2 pyruvate become 2 acetyl-CoA. No difference at all, right? Even when there is high energy, glucose becomes 2 pyruvate. 2 pyruvate become 2 acetyl-CoA. Okay. In due course, the cell realizes that there is already enough energy. So why should I waste glucose by pushing into these pathways which give me only energy? Let me push glucose into alternate routes. Okay. So some of the glucose molecules will stop getting into glycolysis and they start entering into glycogen synthesis. Do you understand this? Some of these glucose molecules will start entering into alternate pathways when you store glucose as glycogen. Okay. Not just that. Some of these glucose 6-phosphate molecules that are formed in the presence of glucose 6-phosphate dehydrogenase, start entering into HMP shunt. In the presence of glucose 6-phosphate dehydrogenase, some glucose 6-phosphate start entering into HMP shunt. So everybody who's watching this session, do you understand the difference between glucose 6-phosphatase and glucose 6-phosphate dehydrogenase? Can you tell me the difference? Glucose 6-phosphatase is an enzyme of gluconeogenesis which converts glucose 6-phosphate into glucose. Glucose 6-phosphate dehydrogenase is an enzyme of HMP shunt. Now, what if glucose 6-phosphate enters into HMP shunt? There are two advantages. One is it acts as a source of NADPH. So tell me, what is one advantage of HMP shunt? It acts as a source of NADPH. So I told you NADPH can never enter into electron transport chain. It can never give rise to energy. I will tell you the significance of NADPH in a short while. Okay, for now, one advantage of HMP shunt is that it gives rise to NADPH. Another significance of HMP shunt is that it acts as a source of ribose 5-phosphate. That is why HMP shunt is otherwise called as pentose phosphate pathway. Do you all understand this? This is why HMP shunt is otherwise called as pentose phosphate pathway. Pentose phosphate meaning ribose 5-phosphate. Okay. So first, let me tell you about NADPH in a very crisp manner. And then we'll discuss about ribose 5-phosphate. Okay. So what is the use of NADPH if it does not give rise to energy? Yeah, there are few applications, but I want you to know about one use of NADPH. The use of NADPH is that it is necessary for regenerating glutathione, which is an important antioxidant mechanism for RBCs. So tell me, what is the major use of NADPH? It is necessary to regenerate glutathione, which is an important antioxidant mechanism for RBCs. Let me tell you that in detail. If you're asked which cell in your body is exposed to maximum oxidative stress, your answer should be RBCs, because RBCs carry oxygen. So tell me, what if it carries oxygen? Some of these oxygen molecules become superoxide radicals. Some of these superoxide radicals, no. So what happens in RBC? Some oxygen becomes superoxide radicals. These superoxide radicals become hydrogen peroxide. Okay. If you allow hydrogen peroxide to accumulate, this hydrogen peroxide will cause oxidative damage to RBC membrane and RBCs will undergo lysis. I don't want this hemolysis. I have to detoxify hydrogen peroxide. How do I detoxify hydrogen peroxide? Using 2 molecules of glutathione. Okay, using 2 molecules of glutathione. So hydrogen peroxide reacts with 2 molecules of glutathione. Both the molecules of glutathione donate 1 hydrogen atom each to hydrogen peroxide, converting hydrogen peroxide to H4O2. H4O2 is nothing but 2 molecules of water. Okay, so this way hydrogen peroxide is detoxified as water. Okay, but in this process, glutathione becomes GSSG. Glutathione has lost its hydrogen atom, so glutathione has become GSSG. I am going to call this enzyme as glutathione peroxidase. Are you clear? I am going to call this enzyme as glutathione peroxidase. If you're all asking me why, it is because I'm using this enzyme to detoxify hydrogen peroxide. I should call it as a peroxidase, for which I am using glutathione. So I call it as glutathione peroxidase enzyme. Okay. Now with this, my work is not yet complete. My work will be complete only when I can regenerate glutathione back. Right? How will I be able to regenerate glutathione back? In the presence of glutathione reductase. That glutathione reductase needs hydrogen source. What will act as a hydrogen source? NADPH will act as a hydrogen source. Do you get it? For regenerating GSH, I need a hydrogen source. That hydrogen source is NADPH. So all of you, please type it in the chat box. If you're asked what is the significance of NADPH, your answer should be NADPH is necessary as a coenzyme for glutathione reductase, which helps in regenerating glutathione, which is an important antioxidant mechanism for RBCs. Okay, now tell me what happens in G6PD deficiency. Okay, start thinking everybody. What happens in G6PD deficiency? Which pathway is inactive? All of you answer. Which pathway is inactive? HMP shunt is inactive. Without HMP shunt, what cannot be synthesized? NADPH cannot be synthesized. Without NADPH, what cannot be active? Glutathione reductase cannot be active. So what cannot be regenerated? Glutathione cannot be regenerated. So what cannot be detoxified? Hydrogen peroxide cannot be detoxified. This hydrogen peroxide that accumulates causes oxidative damage to RBC membrane, and that causes hemolytic anemia. Do you all understand this? That causes hemolytic anemia. So whenever they ask you, what will be the presentation, right? If you're asked, what will be the presentation of G6PD deficiency? What should be your answer? Your answer should be hemolytic anemia after exposure to an oxidative stress. Do you understand this? Hemolytic anemia after exposure to an oxidative stress. So the history will be very classical. The history would say a 15-year-old boy presents with hemolysis after intake of primaquine. Do you understand this? A 15-year-old boy presents with hemolysis after intake of primaquine. Primaquine is a prophylactic drug given for malaria that induces oxidative stress that causes hemolysis. Or 18-year-old boy, okay, presents with hemolysis after intake of fava beans. Do you understand this? After intake of fava beans. So do you see three features common in both the cases that I told you? The first feature that you should observe is age of the patient. Did I say a neonate? I did not. Did I say an infant? I did not. I said a child, right? An older child. Okay. It is because there should be a history of exposure to oxidative stress. Until then, there is no hemolysis. So it is not going to be immediately life-threatening soon after birth. So an older child presenting with hemolysis is what you would see. Second is gender. Did I tell you in both the cases boys, right? It is because G6PD deficiency is X-linked recessive. So what was I telling you? Because G6PD deficiency is X-linked recessively inherited, it is seen predominantly in boys. Yeah. So that is the second fact. Okay. And the third fact is history of exposure to oxidative stress. So tell me, what are the three features that will be common to any G6PD deficiency case? Older child, male sex preponderance, history of exposure to oxidative stress. Okay. So that is the significance of NADPH. Okay. Now, what is the significance of ribose 5-phosphate? Ribose 5-phosphate is like a foundation based on which nucleotides are formed. Do you understand this? What is ribose 5-phosphate? Ribose 5-phosphate is like a foundation based on which nucleotides are synthesized. So for purine and pyrimidine nucleotide synthesis, we need ribose 5-phosphate. Okay, so do you understand what happens when there is high energy? All of you answer. Whenever there is high energy, some glucose will start entering into alternate routes. Some glucose enter into glycogen synthesis. Some glucose enter into HMP shunt. From HMP shunt, we start getting NADPH. We start getting ribose 5-phosphate. Okay. Similarly, when there is high energy, this acetyl-CoA will not get into citric acid cycle. Because what is the purpose of citric acid cycle? To give you 10 ATPs. Already the energy level is high. So I don't want to waste acetyl-CoA by pushing it through citric acid cycle. In that case, acetyl-CoA accumulates. When acetyl-CoA accumulates, that condenses to form fatty acids. So please remember, acetyl-CoA is a building block for fatty acid. Are you clear? Acetyl-CoA is a building block of fatty acid. Then fatty acid is synthesized. Fatty acid will be stored as triacylglycerol. Okay. And the same acetyl-CoA is also used for cholesterol synthesis. And cholesterol will be stored as cholesterol ester. Okay. Cholesterol will be stored as cholesterol ester. That is why whenever you consume a carbohydrate-rich diet, that carbohydrate ultimately becomes fat. Okay, that carbohydrate ultimately becomes fat. And that is why carbohydrate-rich diet is lipogenic. Do you all understand this? This is why carbohydrate-rich diet is lipogenic. So this is what is expected whenever there is high energy. So we learnt what happens in a well-fed state, what happens in starvation. We learnt what happens when there is low energy, what happens when there is high energy. Okay. Now, preferred fuel, right? Preferred fuel for all your cells. Okay. So, preferred fuel for a cell depends upon one statement, which you all know already. Okay. The statement is glycolysis is the only pathway, right? Glycolysis is the only pathway that can generate ATP even in the absence of oxygen. Can you repeat this? What is the statement that you should all remember to know the preferred fuel for all your cells? Glycolysis is the only pathway that can generate ATP even in the absence of oxygen. Okay. So preferred fuel for a cell depends upon whether the cell is aerobic or if the cell is anaerobic. Okay. If the cell is anaerobic, does the cell have any choice but to choose glucose? No. Do you get it? If the cell is anaerobic, the only pathway that can generate ATP is anaerobic glycolysis. So the only fuel the cell can use is glucose. So all anaerobic cells prefer to use only glucose. Example for anaerobic cells using glucose will be RBCs, retinal cells, corneal cells. Do you understand this? RBCs, retinal cells, corneal cells, because they don't have mitochondria. Okay. And then white muscle fibers. I hope you all remember red muscle fibers are red because they have myoglobin. Right? Myoglobin is a storage form of oxygen. When it has a storage form of oxygen, it undergoes aerobic metabolism. So red muscle fibers undergo aerobic metabolism. White muscle fibers without myoglobin will have to undergo anaerobic metabolism. So white muscle fibers can use anaerobic glycolysis. So the preferred fuel for white muscle fiber is glucose, and they store glucose in the form of glycogen. Okay. And then renal medulla. Renal medulla receives very low blood supply. Okay. Because it receives very low blood supply, it has low access to oxygen. So renal medulla also undergoes anaerobic metabolism. So all of you tell me, what are the anaerobic cells which use glucose as the fuel? RBCs, retinal cells, corneal cells, because they don't have mitochondria. White muscle fibers because they don't have myoglobin. Renal medulla, which receives very low blood supply. Okay. These cells are dependent on glucose. Now, what if it's aerobic? Aerobic cell can either use glucose aerobically, or these cells can use fatty acids aerobically. right? Both glucose and fatty acids can be used aerobically. Given a choice, a cell will choose only fatty acids because fatty acids on oxidation will give you more number of ATPs than glucose on oxidation. Are you clear? Fatty acids on oxidation will give you more number of ATPs than what glucose can give. So if I give you a choice, you will choose fatty acid. That is why aerobic cells prefer to use fatty acids. Okay. Example for aerobic cells using fatty acid is cardiac muscle fibers and red muscle fibers. Cardiac muscle fibers are known for their mitochondrial content. With numerous mitochondria, they use aerobic metabolism. So their preferred fuel is fatty acid. Red muscle fibers with myoglobin undergo aerobic metabolism. So their preferred fuel is also fatty acid. So red muscle fibers store fatty acid as triacylglycerol and as cholesterol ester. Do you understand this? Red muscle fibers store fatty acid as triacylglycerol and as cholesterol ester. And this is why you should not consume red meat. Have you been asked to refrain from having red meat? Yeah, it's because red meat is rich in triacylglycerol and cholesterol ester. If you consume red meat, you end up getting hypertriglyceridemia and hypercholesterolemia. Okay. Now there is an exception to this rule, where an aerobic cell continues to use glucose. Despite knowing that glucose gives less ATP, there is one aerobic cell which uses glucose, and that is neurons. Do you understand this? What is it? It is neurons, because neurons are surrounded by blood-brain barrier. Don't you know that? Neurons are surrounded by blood-brain barrier, and any fatty acid that is present in the circulation is attached to albumin. Right? Any fatty acid that is present in the circulation is attached to albumin. As long as it is attached to albumin, it cannot cross the blood-brain barrier. Neurons do not have an access to fatty acids, so they have no other go but to use glucose. Do you get it? So neurons use glucose aerobically. Do you understand this? Neurons use glucose aerobically. RBCs use glucose anaerobically. Are you clear? So tell me what happens to one molecule of glucose that enters into RBCs. The one molecule of glucose that enters into RBC has no other go but to become 2 lactate and 2 ATPs, because RBCs are anaerobic. If the same glucose enters into neuron, that glucose becomes carbon dioxide and it gives you 32 ATPs. That is the difference between how glucose is used in RBCs and how glucose is used in neurons. Okay. So that's all about preferred fuel for a cell. Okay. So based on this, can you try answering this NEET 2022 MCQ? Primaquine can precipitate hemolytic anemia in individuals with an enzyme deficiency. The enzyme is related to which pathway? What will be your answer? Hemolytic anemia after primaquine. The enzyme is G6PD deficiency and the pathway is HMP shunt. Okay. So now, hemolytic anemia, what are the metabolic causes? Okay. There are two metabolic causes for hemolytic anemia. One we know is G6PD deficiency. The other one is glycolytic enzyme defect. Do you understand this? The other one is glycolytic enzyme defect. So, you should ask me, why should glycolytic enzyme defect present with hemolysis? It is because for glycolysis, for which cell is glycolysis indispensable? For which cell is glycolysis indispensable? Glycolysis is indispensable for RBCs and white muscle fibers. Right? Glycol is indispensable for RBCs and white muscle fibers. So whenever there is a glycolytic enzyme defect, RBCs get affected the most. When RBCs get affected, all of you please watch this carefully. When RBCs get affected, in this case, RBCs are not able to generate ATP. Without ATP, the sodium-potassium ATPase pump fails. You know, all your cell membranes have sodium-potassium ATPase pump. This pump pumps out 3 sodium ions, and this pump reciprocally takes in 2 potassium ions. Both ionic movements are against gradient. Intracellular fluid is already rich in potassium. It is taking potassium inside. Extracellular fluid is already rich in sodium. It is taking sodium outside. So both ionic movements are against gradient, for which you know this transporter needs ATP. Okay, that ATP in RBC should come from glycolysis. So whenever there is a glycolytic enzyme defect, ATP is not generated. So sodium-potassium ATPase pump cannot work. So what cannot be pumped out? Sodium ions cannot be pumped out. So sodium accumulates within RBCs. When sodium accumulates within RBCs, because sodium is osmotically active, it attracts water. RBCs swell and RBCs undergo rupture. So can you tell me what will be the principal presenting feature of any glycolytic enzyme defect? It will be hemolytic anemia. Hemolytic anemia because sodium-potassium ATPase pump cannot work in the absence of ATP. When white muscle fibers get affected, it will present as exercise intolerance. Right? When white muscle fibers get affected, it will present as exercise intolerance. Intolerance to anaerobic exercises. Okay, why only to anaerobic exercises? If you ask the person to perform some aerobic exercise, if it's aerobic metabolism, what will be the preferred fuel? For aerobic metabolism, it is fatty acid. In this person, fatty acid oxidation is perfectly normal. So as long as you ask your patient with glycolytic enzyme defect to run or jog or swim, right? Running, jogging, swimming, all these are aerobic exercises. As long as you ask them to do any of these aerobic exercises, they use their fatty acids, they use their fatty acid oxidation, the person will happily do it. But only when you ask the person to perform some anaerobic exercise, like clenching the fist, right? Pushing something against resistance, that is when they complain of muscle cramp. Glycolytic enzyme defects present with exercise intolerance, intolerance to anaerobic exercises, and hemolytic anemia. Okay. So what are the glycolytic enzyme defects that you know? It can be phosphofructokinase 1 defect, which is the rate limiting enzyme defect, or it can be pyruvate kinase defect. Okay, phosphofructokinase 1 defect, or it can be pyruvate kinase defect. Phosphofructokinase 1 defect is nothing but Taruv's disease. Okay, phosphofructokinase 1 defect is nothing but Taruv's disease, which is type 7 glycogen storage disorder, or it is pyruvate kinase defect. Okay, so how will you differentiate whether it is G6PD deficiency or is it glycolytic enzyme defect? The history. G6PD deficiency, late childhood, male sex preponderance, history of exposure to oxidative stress. Whereas if it's glycolytic enzyme defect, it is not only hemolytic anemia, additionally you see exercise intolerance. Okay, so this is how you find out what metabolic cause is the reason for hemolytic anemia in a patient. Do you all understand this? I'm waiting for you to give me the answer. What is the metabolic fuel for RBCs during starvation? Be it in a well-fed state or in a fasting state or in starvation, RBCs can use only one fuel, which is, they can use only one fuel, which is glucose. Yes. So introduction to metabolism is over. Now metabolism proper. So which of the following are fates of pyruvate? all the following are fates of pyruvate except, okay, Snigdha and all students, right? So white muscle fibers can perform aerobic exercise or anaerobic exercise. Okay. If a white muscle fiber performs aerobic exercise, it uses fatty acid through fatty acid oxidation. Okay. But if a white muscle fiber performs anaerobic exercise, it has to use glucose. And most of the exercises that we all perform belong to anaerobic exercise type. That is why most of the times they use glucose. I hope it's clear to everybody. Yeah. So all the following are fates of pyruvate except. What will be your answer? Valine. Okay. So does that mean pyruvate can form acetyl-CoA? Yes, pyruvate can form acetyl-CoA. That is done by which enzyme? Pyruvate dehydrogenase complex. Can pyruvate form lactate? Yes, in the presence of lactate dehydrogenase. Can pyruvate form alanine? Yes, by a transaminase. Pyruvate is a keto acid which undergoes transamination to form an amino acid which is alanine. Okay, but pyruvate cannot form valine. So the answer for this question is valine. But let me tell you about all fates of pyruvate. Okay, let's discuss about all fates of pyruvate. So please remember, pyruvate is a central metabolite and this pyruvate can have multiple fates. Okay, pyruvate is a central metabolite. This pyruvate can have multiple fates. And the choice of fate depends upon the energy status of the cell. Okay, what if the energy status of the cell is low? And what if the energy status of the cell is high? When the energy status of the cell is low, fate of pyruvate is dependent on whether the cell is aerobic or the cell is anaerobic. Okay, low energy, anaerobic cell. The only pathway that can generate energy is glycolysis. For continuously running glycolysis, pyruvate should become lactate. Done by which enzyme? Lactate dehydrogenase. Do you understand this? Low energy, anaerobic cell, every pyruvate that is formed would become lactate in the presence of lactate dehydrogenase. Now, low energy aerobic cell, right? In that case, pyruvate will be used for further energy production, for which pyruvate should enter into citric acid cycle, for which pyruvate should become acetyl-CoA. So tell me which enzyme converts pyruvate into acetyl-CoA? Pyruvate dehydrogenase complex. Okay, this is about what happens when there is low energy. When there is high energy, fate of pyruvate is dependent on whether the person is well fed or the person is in starvation. Do you understand this? When there is high energy, fate of pyruvate is dependent on whether the person is well fed or the person is in starvation. A quick question to all of you. When you're in starvation, what will be your primary aim? Your primary aim will be to maintain blood glucose. Do you all understand this? When you're in starvation, you forget about everything else. You have only one aim, that is to maintain blood glucose. To maintain blood glucose, gluconeogenesis should be stimulated. For gluconeogenesis to happen, all pyruvate should become oxaloacetate. Didn't I tell you? For pyruvate to be used for gluconeogenesis, all pyruvate should become oxaloacetate. The enzyme which converts pyruvate into oxaloacetate is, can you all answer? The enzyme which converts pyruvate into oxaloacetate is pyruvate carboxylase. Okay. Now, high energy, well-fed state, which means everything is available. There is energy, there is fuel. Put together, let's use pyruvate for some anabolism. How can you use pyruvate for anabolism? By converting pyruvate into alanine. Do you understand this? Excellent. Very good. By converting pyruvate into alanine. The enzyme which converts pyruvate into alanine is a transaminase. Right? What is the name of the enzyme? It is a transaminase. So can you all repeat this? Yeah. So what should you repeat? You should start telling me what are the fates of pyruvate. Okay. So pyruvate is a central metabolite. It can have multiple fates, and the choice of fate depends upon the energy status of the cell. When the energy status of the cell is low, fate of pyruvate is dependent on whether the cell is aerobic or anaerobic. If the cell is anaerobic, close your eye and say pyruvate becomes lactate by lactate dehydrogenase. If it is aerobic, pyruvate becomes acetyl-CoA done by pyruvate dehydrogenase complex. Now, high energy. When there is high energy, fate of pyruvate is dependent on whether the person is well-fed or the person is in starvation. If there is starvation, you have to forget about everything else. Your only aim is to maintain blood glucose. To maintain blood glucose, gluconeogenesis has to be stimulated, for which pyruvate should be converted to oxaloacetate. Okay. High energy, well-fed state. So pyruvate should be used for anabolism, for which pyruvate should be converted to alanine, done by a transaminase. Okay. So a quick recap for all of you about transaminases. I'm not going to get into the depth of transaminases. Can you all tell me what are the two transaminases that you always write in liver function test? The two transaminases are AST, otherwise called as SGOT. Okay, AST is otherwise called as SGOT. ALT is otherwise called as SGPT. Okay, ALT is otherwise called as SGPT. If you're asking me how to remember this, let me give you two mnemonics for this. So and LP are lumbar puncture, right? So or LP or lumbar puncture. What are we going to use this to remember? Okay, you can remember that aspartate, all of you listen to this, aspartate on transamination forms oxaloacetate. Oxaloacetate on transamination forms aspartate. Are you clear? What did I tell you? Aspartate and amino acid on transamination forms oxaloacetate. Alanine and amino acid on transamination forms pyruvate. Okay, so AST is otherwise called as SGOT. ALT is otherwise called as SGPT. Please remember, all these transaminases need pyridoxal phosphate. You all understand this? All these transaminases need pyridoxal phosphate as a coenzyme. I will ask you this towards the end of the session today. All transaminases need what? Pyridoxal phosphate. Okay. So tell me, what is the right answer? All the following of fates of pyruvate except. Yeah, the answer is valine. All the following are coenzymes of pyruvate dehydrogenase complex except. Okay. So just remember, PDH complex catalyzes an oxidative decarb. Very good. Excellent. Pyruvate dehydrogenase complex catalyzes an oxidative decarboxylation step. Are you clear? It catalyzes an oxidative decarboxylation step. Biotin is necessary for carboxylases. Okay, biotin is necessary for carboxylases. Already I told you B6 is necessary for transaminases. Biotin is necessary for carboxylases. PDH complex catalyzes an oxidative decarboxylation step. For decarboxylation, we don't need biotin. Okay. Otherwise, yes, thiamine is needed. Yes, riboflavin is needed in the form of FAD. Niacin is needed in the form of NAD. Okay. So, I'm going to tell you all facts about PDH complex now, because that is very essential for you to understand many concepts in metabolism and to be able to answer many MCQs. Okay. So, pyruvate dehydrogenase complex The first fact you all know, where is it present? Cytoplasm or mitochondria? I told you PDH complex is present in all of you, present in mitochondria. That is point number 1. Point number 2 is it catalyzes an irreversible step. PDH complex catalyzes an irreversible step. Okay. So what does it mean? PDH complex can convert pyruvate into acetyl-CoA. But never can you convert acetyl-CoA back into pyruvate. Do you all understand this? PDH complex can convert pyruvate into acetyl-CoA, but never can you convert acetyl-CoA back into pyruvate. That is why acetyl-CoA is never gluconeogenic. Okay. If you're asking me when will I call something as gluconeogenic, only when I know that a substance can enter into glycolysis, I will call it as gluconeogenic. Because if it can get into glycolysis, wherever it enters into glycolysis, from there I can reverse glycolysis, I can reach glucose. Do you get it? But in this case, acetyl-CoA cannot get into glycolysis because PDH complex is irreversible. And that is why acetyl-CoA is never gluconeogenic. And this is why even chain fatty acids are never gluconeogenic. Because even chain fatty acids on oxidation give rise to acetyl-CoA. So what are the facts that you have learned? Acetyl-CoA is never gluconeogenic. So even chain fatty acids are never gluconeogenic. Okay, so that is about it being an irreversible step. And then it catalyzes an oxidative decarboxylation reaction. Okay, it catalyzes an oxidative decarboxylation reaction. It means it simultaneously oxidizes and decarboxylates pyruvate. When it oxidizes pyruvate, it removes hydrogen from pyruvate. It gives that hydrogen to NAD forming NADH. When it decarboxylates pyruvate, carbon dioxide is released. And the major product of PDH complex is acetyl-CoA. Okay, so tell me what are the 3 products of PDH complex? Acetyl-CoA, NADH and carbon dioxide. If these 3 are the products of PDH complex, what should be the substrates of PDH complex? So after we are done discussing this MCQ, I'll give you a 5 minutes break. You can go have a coffee or a tea and you can come back. So what are the products of PDH complex? Acetyl-CoA, NADH and carbon dioxide. If these are the products of PDH complex, what are the substrates of PDH complex? Pyruvate, NAD and CoA. Okay, pyruvate, NAD and CoA are the substrates. Okay. Now, as the name indicates, it's a complex made up of 3 subunits. Do you understand this? It's a complex made up of 3 subunits. Those 3 subunits are named as E1, E2 and E3. Okay, those 3 subunits are named as E1, E2 and E3. E1 is named after the entire enzyme complex, pyruvate dehydrogenase. Though you call it as pyruvate dehydrogenase, it is a pyruvate decarboxylase because this is the enzyme that releases carbon dioxide. So tell me what is E1? E1 is pyruvate dehydrogenase or pyruvate decarboxylase. E2 is dihydrolipoyl transacetylase. Okay, E2 is dihydrolipoyl transacetylase. E3 is dihydrolipoyl dehydrogenase. Okay, E3 is dihydrolipoyl dehydrogenase. So tell me the 3 subunits of PDH complex. Pyruvate dehydrogenase or pyruvate decarboxylase. This was asked recently in NEET PG and this question was also asked in this test. Right, you were given an image-based question asking E1 and E2 are, right? So E1 is pyruvate dehydrogenase or pyruvate decarboxylase. E2 is dihydrolipoyl transacetylase. E3 is dihydrolipoyl dehydrogenase. Okay. Now, what are the coenzymes? Easy to remember. E1 uses B1. Easy, right? E1 uses B1. What is B1? Thiamine pyrophosphate. E2 uses lipoamide. Okay, E2 uses lipoamide and CoA. Do you understand this? E2 uses lipoamide and CoA. E3 is dihydrolipoyl dehydrogenase, which removes hydrogen, gives that hydrogen to its coenzyme, that is FAD, that becomes FADH2, that is then given to NAD forming NADH. Okay, so tell me the 5 coenzymes of PDH complex. E1 uses B1 or thiamine pyrophosphate. E2 uses lipoamide and CoA. E3 uses FAD and NAD. Okay, so these are the 5 coenzymes. And the last fact about PDH complex is it is inhibited by arsenite. PDH complex is inhibited by arsenite. So that's all about PDH complex. So what did we learn about PDH complex? Where is it present? Mitochondria, right? And then I told you it catalyzes an irreversible step. It catalyzes an oxidative decarboxylation reaction. So what are the products of PDH complex? Acetyl-CoA, NADH and carbon dioxide. What are the substrates? Pyruvate, NAD and CoA. E1 is pyruvate decarboxylase. E2 is dihydrolipoyl transacetylase. E3 is dihydrolipoyl dehydrogenase. 5 coenzymes: thiamine pyrophosphate, lipoamide, CoA, FAD and NAD. And it is inhibited by arsenite. Okay. So tell me the answer for this question. Identify E1 and E2. E1 is decarboxylase. E2 is transacetylase. Okay. So choice B. Which of the following is not a glucogenic substrate? It is acetyl-CoA, because PDH complex catalyzes an irreversible step. Yes. Following an early morning run, a 29-year-old man consumes a carbohydrate-rich South Indian breakfast. Which of the following will most likely be activated in his liver after breakfast? Right? So after having a carbohydrate-rich meal, which hormone will be released into the circulation, everybody? Insulin will be released into the circulation. When insulin is released, as I told you, insulin being an anabolic hormone stimulates all anabolic pathways. What are the anabolic pathways? I told you insulin stimulates. It stimulates glycolysis. And we know phosphofructokinase 1 is the rate limiting enzyme of glycolysis. So insulin stimulates phosphofructokinase 1 in the well-fed state. How about other choices? The answer is choice C. But let's exclude other choices, right? You'll have to always do that. How about cytoplasmic pepCK? Cytoplasmic pepCK is an enzyme of gluconeogenesis. Will you be stimulating gluconeogenesis when a person is already well-fed? No. So insulin is not going to stimulate cytoplasmic pepCK. So I hope you're all back. Yeah. So it is not choice A. How about choice D? Cytoplasmic glycogen phosphorylase. Cytoplasmic glycogen phosphorylase is an enzyme of glycogenolysis. And glycogenolysis need not be stimulated when the person is already well-fed, right? How about membrane GLUT4 transporter? Yes, insulin stimulates GLUT4 transporter upregulation. You know that, right? GLUT4 transporters, everybody. Please remember, insulin-dependent glucose uptake happens in skeletal muscle, cardiac muscle, and adipose tissue by GLUT4 transporter upregulation. So yes, it will stimulate GLUT4 in skeletal muscle, cardiac muscle, and adipose tissue. But the question is, will it be activated in liver? Liver does not have GLUT4 transporter. Liver has which transporter? GLUT2 transporter. So it is not going to stimulate choice B. How many of you chose choice B? Many would have chosen choice B because you see insulin and then you see GLUT4 transporter. I know this is a distractor. That is why this is how MCQs are asked, and that is why you should read the question in entirety. Right? Every part of the question carries a meaning. You should be very, focused when you read a question. Sky, it's not a problem. This is the time when you'll have to learn, right? What kind of mistakes you commit. So the answer is choice C. Now the next MCQ, a breastfed infant begins to vomit frequently and lose weight. Several days later, she is jaundiced, her liver is enlarged and cataracts are noticed in her lenses. Okay, she is diagnosed with classical galactosemia. The enzyme responsible for cataract in this condition is. So those of you watching this session, whenever you're given a case-based MCQ, do not panic, right? You should be very happy to see a case-based MCQ because in that case, you will get lots of clues, okay? All that you will have to do is follow few steps. Step number 1, find out what is the question about. Don't start reading the question from the first word till the last word. Look at the stem of the question. In the stem of the question, first read what is the question about. What have they asked you? The enzyme responsible for cataract in this condition is. That is the question. Then you start reading the case, right? When you start reading the case, of course, there are so many other facts that are given. Jaundice, liver is enlarged, cataract. But they've given you the diagnosis. What is the diagnosis? Classical galactosemia. Right? We know classical galactosemia is caused by the defect of GalPut. Even if you've forgotten, please memorize it. Classical galactosemia is caused by the defect of GalPut. What is GalPut? Galactose 1-phosphate uridyl transferase. But they have not asked you classical galactosemia is caused by the defect of which enzyme. They're asking you in classical galactosemia, which enzyme is responsible for cataract. So you should understand the basis of it. So in galactosemia, as the name indicates, galactose level in the blood is high. Right? Whenever galactose level in the blood is high, this galactose enters into lens. When it enters into lens, as long as it is in the form of galactose, you don't have to worry about it. Through the same transporter through which galactose enters into the lens, it can come out of the lens. Okay, but the enzyme that is present in lens is aldose reductase. All of you please repeat this. Which enzyme is present in lens? Aldose reductase, which reduces the aldehyde group of aldose to form an alcohol. That alcohol that you get is galactitol or dulcitol. This alcohol accumulates within lens. This being osmotically active, it attracts water. So the lens fiber cell swells and that begins cataractous changes. So if they ask you what is the cause of classical galactosemia, your answer should be GalPut. But if they ask you which enzyme is responsible for cataract in galactosemia, your answer should be aldose reductase. If they ask you which alcohol is responsible for galactosemic cataract, your answer should be galactitol or dulcitol. If they ask you what kind of cataract do you see in galactosemia, it is oil drop cataract. Do you understand this? It is oil drop cataract. Now, all the following are components of mucopolysaccharides except mucopolysaccharides do not have N-acetyl-nuraminic acid. Do you understand this? Mucopolysaccharides do not have N-acetyl-nuraminic acid. Very good, Sejal. Yeah, so N-acetyl-nuraminic acid is present in glycolipids. So it is time that we learn about mucopolysaccharides. Okay, so let me tell you all about mucopolysaccharides now. There are many questions that are asked in this topic. They ask you structure-based MCQs or they ask you location-based MCQs. right? Even in this test, I had given you one NEET PG question, wherein they asked you the mucopolysaccharide that is present in glomerular basement membranous, right? That is heparin sulfate. So now I'm going to tell you about the structure of mucopolysaccharide and about location of mucopolysaccharides, for which I will be telling you few thumb rules. Okay, so I will be telling you few thumb rules and then few exceptions. Okay, my best wishes to all of you. Yeah, thank you.